right. Thanks again to Dr. Stokes. Now, I want to highlight the specific formatting that will actually make this Long COVID Physio Forum special. Program content will be delivered covering 3 different types of streams. And we're about to experience that first type of presentation format, which we're calling science. Now, these science presentations are research presentations given by world leaders that are then summarized by a patient-led panel. You'll see this type of stream throughout the 2 days of this forum. Next up for you, our first science session will help you better understand long COVID rehabilitation care models, including referral principles, service delivery setting, and workforce. After you're done listening, you'll be able to more clearly understand the components and functions of long COVID rehabilitation care models. Again, a patient-led panel discussion will also follow. To help you learn now, it's my pleasure to introduce Dr. Simon Décary.
Hello, everyone. Thank you very much for this awesome presentation. It's truly an honor for me to be with you today. I'm just going to share my presentation. Is it on screen?
Yes, all good, Simon.
Perfect. Okay, so I'm going to start now. So thank you very much for the invitation. Truly an honor to be with you, my friends and colleagues today. And so I'm going to start the science stream with this presentation of health system and rehabilitation care. And I look forward, so I'm going to talk for about 10 to 15 minutes, and then we're going to join the panel with my colleagues to discuss key implementation and equity about health system response. So my name is Simon Décary. I'm Assistant Professor of Rehabilitation at the University of Sherbrooke in Quebec, Canada. And so currently, my main research program is about studying health systems responses to long COVID. So I'm going to talk a bit with you about this story. I know there are too many slides and it's going to go fast. I just wanted to keep the content there so that you have access and time to look at more detail about this content later on your own time. Perfect. So for the first 5 minutes, I think I need to make an evidence update that currently impact health system response to long COVID, because there are many new things that happened in the last few weeks and the last few months, and we need just to consider the context before we go into more detail. So first, let's talk about the differential diagnosis of long COVID. We had a clinical case definition that was published by WHO October 6th. So the definition is close to be 1 year old. And that was very a key moment in the story of long COVID. It helped us to recognize the condition and explain the condition to many different healthcare professions. However, the evidence kept building, and now we have new evidence that the umbrella term of long COVID or post-COVID-19 condition, as they term it in WHO, is actually way more complex than initially thought. And there are new reports about increased risk of cardiovascular condition, increased risk of diabetes, increased risk of different neurological condition. And that all fell under the umbrella of long COVID. So it's more, we are moving on more from symptoms to a differential diagnostic approach. And this is very important for a profession like physiotherapist, because we have clinical skills that will help patients make sense of their current diagnosis and perhaps subgrouping the patient. So this is where we are going with the evidence. And of course, a complex differential diagnosis leads to complex core outcome domains and core outcome measures for these patients, because we will want to have standardized outcome measures for our patient to guide them with processes like insurance companies and everything related to disabilities. And the complexity of the diagnosis is mirrored in the core outcome domain. So WHO is continuing their work, and currently there are 11 core outcome domains that are currently under investigation. And for people who are more familiar with the process, 11 core outcome domains for one condition is actually a lot, which means that it's a complex condition, and we will have multiple tools that we will need to include in our clinical practice. And this all influence how you design a care model and how you serve patients. We cannot talk about long COVID today without talking about the prevalence of long COVID in the Omicron era. And you need to conceptualize that the era prior to Omicron in January this year is a little bit different, okay? Both in terms of the new variant, the way it impacts health, as well as health system response to protecting the population. So as we know, in most countries today, there are almost no barriers anymore for infection except for vaccination, and that influenced the prevalence of long COVID. And this report was published just a few weeks ago. And it's very interesting because it's the prevalence, and it's the first report using a fully prospective cohort with a very high quality control group. And they still found 12.7% of patients meeting the definition of long COVID at 12 weeks after controlling for the control groups. And so that's a significant number of people. But the critics of this paper was actually on a cohort before the Omicron era. So what do we know now? We know now that vaccine appears to give some kind of protection against long COVID. Depending the report, you're going to find between 15 and 20% and 50% of protection. So the key point here is that we know that you can get long COVID above triple vaccination, above a Omicron infection. So we now have this data to know that there are breakthrough cases of long COVID. And again, this influences how you design a care model and health system response. What's the best number we have? Again, it's still with the ONS data from the United Kingdom, who are continuing their surveillance. And the way they see it right now, they calculated it as a percentage of the whole population. So the latest estimate in August were at 2.8% of the population having symptoms of long COVID. So this is very important for health system organizer because it helps you compare with other disease to know how much investment you need for access to care. And overall, these estimates also propose that currently, at this stage with vaccination and Omicron, we're talking about the 4 to 5% of all cases who are going to develop persistent symptom at 12 weeks. And this is very important because we may have reached a steady state of approximately 1 infection per year per person in the overall population. So what does this mean? This means that we may have a new chronic disease on our hands. So these are the current numbers. And we also have new data about prognosis. So we knew from previous wave that approximately 30% of all people with long COVID at 12 weeks were going to develop persistent symptoms for more than a year. So if you add vaccine protection to that, we're maybe talking about 20%. And we won't have these numbers for Omicron before January this year, so all 1 year cycle. So this will also influence what we know. And there are new reports. And so you have the number of patients. That's what we look when we think about health system response, but you also need to know about the level of disability. So we already know that we're talking about 100 million, 150 million people currently suffering of that. This is a significant number. But what is the level, the spectrum of disability? And this group, so it's still in preprint, but when you look at the authors, you know that's going to be published quite very soon. The report is significant. And they were the first team to actually measure the level of disability. And the level of disability for long COVID is equivalent to severe neck pain, Crohn's disease, or moderate to long-term traumatic brain injuries. So this is important because normally these diseases are in the health system are going to go to a pathway for rehab centers or that kind of structure and follow-up. But we need to come up with ideas to do the same thing within community-based rehabilitation. So this is a challenge. And again, we need to talk about Kelly O'Brien, exceptional person. And there is a complete session in this forum about this, about episodic disability. So we know that some patients are going to recover during 3, 6, 9 months, and others are going to be impacted perhaps permanently. So two level of disability, two patterns of disability, and this again influence how you propose your care model. So I'm going to put a sentence here, and this is the first time, so I feel confident to talk with this group about this. This is an extrapolation. This is the first time I'm going to put this sentence out there, so we need to discuss. It's an extrapolation. That's not like the actual number, but this is what I'm thinking about when I discuss with decision makers. Based on everything I just showed you, is it possible that 1% of the worldwide population may become disabled every year because of long COVID? So if you start from 5% with the prognosis, with the overall landscape of increased risk of different condition, is it possible that we are facing 1% disability of the whole population? So what is 1%? I'm beginning the work to compare with other disease. So this is not official number, but 1% would mean twice as many new cases as traumatic brain injuries each year, twice as many as stroke, 4 times as many cancer, and twice the doubling the ME/CFS rate in the population. So even if it was not 1%, even if it's what half than that, we're talking about a significant number of patients affected every year. And so this is why this is driving international health system response. And I'm going to tell you a little story about how it evolved since the beginning of the story of long COVID. So all what I'm going to show you is in these 2 evidence report. You can find them online. They are free. So just type in care model for long COVID, SPOR Evidence Alliance in Google, and you're going to find them up front. They are freely accessible. So we've been doing this surveillance since summer 2021. So it's more than a year that we've started this work of surveying health system response. So we have to report. The first update was done in December 2021, and we are currently doing the new update. So we're going to, by December 2022, we're going to have the new update of health system response published from our team. And there are some very interesting stories that happened. So we know from this work that the first international leader was actually the United Kingdom, who in November 2020 made the first national investment in more than 20 post-COVID assessment clinics. And they followed that up with an expansion of services in June and July 2021. And they were the first to implement this at the national level, and it cost more than £100 million. So that's the cost of a first national response to long COVID. And now it kept building, and we have more in the UK. They have more than close to 90 clinics that are currently running for long COVID patients. And this pioneer work was very important because it allows us to have very rapidly data and evidence about the different cohorts, the different pathways, such as this report from Melissa Aitman. Very important paper to understand the different pathways, and this led the NICE organization in the UK to propose different care pathways, including the integration with primary care. So we're not going to go into too much detail. You can have the time to look at this after. Again, at the beginning, the United Kingdom were not the only one to start experimenting care models. And we found many other papers. And it's interesting because we found a total of 30 healthcare professions that were proposed in different models to help patients with long COVID. And we divided more than 30 principles and components, such as using multidisciplinary team, having structure for coordination of care, standardized assessment, follow-up systems. So all these are principles and components that were tried in the last 2 years to help these patients. And this conceptually allows us to draw this prior work, a structured pathway that could be used. And again, so what's interesting in the current evidence about this is that whether you have a patient with that comes with a sequelae from hospitalization for COVID, or a patient with long COVID from the community, you need to have some kind of post-COVID assessment and triage structure in your model to really do the multi-systemic assessment. And that's very interesting because there are not that many professions that can actually staff such a structure. You can have a physician, a nurse practitioner, and most importantly, you can have a physiotherapist to take this advanced practice or primary care role to support in the differential diagnosis of these patients. So very important. And once the patient have gone through this post-assessment triage, we found 3 different interfaces in which the patient is going to interact. So rehabilitation, specialized rehabilitation services, depending on the impairments that the patient has. You need to have specialty care all coordinated into this because you will need to have access to imaging tests, blood tests to further the differential diagnosis, and you will need to interact with primary care for coordination with the general practitioner, social worker, nursing, or pharmacist. So that's the overall landscape of the framework for a care model right now. And as the evidence built, we saw some principle and component that became more clearly identified as every care model should have these kind of element in their model. So I will let you look at the details in the published paper to better understand this, and we'll discuss this in a few minutes with our panel. We were also able with the WHO team to go into with Cochrane Rehabilitation to publish another review. So this review was accepted. So it is going to be published very soon in the WHO bulletin. And what we did, so again, I'm showing this to you just to show you the level of detail that we can have right now. So this is only for rehabilitation care. So this shows you the level of detail that we can go in designing rehabilitation care models. So we know how to design the component and function. We know which personnel is the workforce. We know how to different way of delivering the services, the timing, the criteria, and the safety netting procedure. And we were able to design some key policy messages for health organizers. So my main message here is that the international community knows how to build rehabilitation care models for long COVID. So this is very important. Conceptually, we know how to do this. So we don't need to wait to start building this in many countries. And of course, this triggers national responses. So just a quick overview, the United Kingdom is still our leaders, and they have very important research program right now, including the locomotion study, who is going to help us understand the standard of care with a focus on equity and access. They are going to run the first adaptive clinical trial of medication. The United States is following very soon with a $1.15 billion investment. And in August, they were able to publish their national research plan, again, in phases of Center of Excellence with 40 clinics as part of the PASS collaborative, again, with an impact on equitable access to care. And of course, Canada, we're going to do our part. And in Quebec, we're going to have a 20.5 million investment in 15 clinics for long COVID, which will allow us to participate in the research effort. So that's the overall view of what is happening. And now I'm turning to our panel members because we need to discuss very key elements about implementation and about equity. So I propose here 6 different challenges. And I would like the panel to discuss your role in your care models, and then perhaps select 1 or 2 challenges from the list and talk about how, in your experience, you were able to resolve these challenges. So rapidly, the challenges is about how to avoid duplication and real-time sharing of evidence of successes and failure, how to train international healthcare workforce, how to build a financially sustainable model integrated with primary care, how to link with insurance companies, how to support low and middle income countries, and how to mobilize knowledge to other post-infectious conditions. Thank you very much for this time. And now I turn to the panel. Jimmy, do you want to introduce the panel members?
Yeah.
Thank you very much.
I get paid by the word, so don't steal any of my thunder. First of all, Dr. Décary, thanks so much for batting lead off and trying to follow Dr. Stokes. We do want to reiterate, we want this to be as interactive as possible. So if you'd like to ask any the guests questions or spark an idea, you can use that chat feature on Zoom, and some of our staff will whisper it into my ear so I can ask it of our panel. Let's bring them in. Let's welcome Lisa McCorkell, co-founder, Patient-Led Research Collaborative in the USA. Welcome, Lisa. Anne Lee, Long COVID Europe in Belgium. Welcome, Anne. And Professor Nicola Kays, Professor of Rehabilitation and co-director of the Center for Person-Centered Research, Auckland University of Technology, New Zealand. Guests, welcome. When hearing Dr. Décary speak, he sort of led you off with a choose your own adventure. He let you pick from those 6 categories. I'll give you a 7th. What thoughts and feelings came to mind when you were listening to Dr. Décary speak? And I want to make sure all of you get a chance to chime in. So why don't we start with Lisa, then Anne, then Professor Kays. So Lisa, you get to bad lead off. When you were sitting there listening to Dr. Décary speak, and I'm sure you were thinking about what you were going to get to talk about here in the forum, what thoughts and feelings were coming to your mind first?
Sure. Thank you. And thanks for having me. I think there's a lot of these clinics that are popping up throughout the world. And I think it is a good initial response to the long COVID crisis. But one of the things that I feel like is missing from the literature and when talking about kind of setting up these clinics is really the quality of care that's being received by patients. And what we've seen within the patient community is that it really is hit or miss. Patients can receive really great quality of care, providers who are up to date on post-viral illnesses, on long COVID, on all of the research, or, you go in, you get a few tests, maybe a couple blood tests, told it's, there's nothing really they can do for you, sent home, worst case, sent home with graded exercise therapy and cognitive behavioral therapy as treatment when that's contraindicated within long COVID. So it's really important when considering building these models that also a huge part of that is the patient experience. What is the patient experiencing in that? So while we do need the infrastructure for this huge crisis where, like Simon said, 1% of the world's population could be disabled every year from COVID, we need to make sure that those patients are getting quality care.
Lisa, thanks so much for that. Anne, let's turn to you.
I'd like to agree. I think that the same thing, we've been seeing the same, I'm so sorry, I'm really tired today. We've been saying the same thing with long COVID Europe, that the quality of care, the access to proper care and the affordability of care mustn't depend on where you live, on which country or which region it may be, and it must be accessible for everyone. It's not because you are lucky enough to live in a certain country or place that you should be able to receive care. And another thing that comes to mind is when I look at the pretty charts with the care models, is that what I see here in Belgium, because I live in Belgium, is that often when you talk about care models, it becomes a very technical and scientific debate. And the problem with long COVID is that there is just not enough known about this condition to know properly what's important. And I think that's why it's really important to include the voice of the patients, because we know where the what's it called in English, the black spots are, things that other people don't know. And we know what works and what doesn't work. So when those care models are implemented, I think it's crucial that patients are asked how those things are going and where the problems arise.
Thank you so much for that insight. Professor Case, when you're when listening to that, you get to follow all three of those speakers. What comes to mind?
Kia ora, thank you so much for having me. I admit that I'm feeling a little bit incoherent, so hopefully I can make some sense to people. I think I really support what Lisa and Anne have just shared. I think for me, one of the things that I think about when I look at the care model is that there's lots of language there that we see a lot in rehabilitation. You know, we talk a lot about people-centered care. We talk a lot about multidisciplinary teams. We talk a lot about integrated care pathways. All of that language is really familiar to us, but what really matters is how that is implemented and whether or not it's implemented in a way that truly reflects the experience of people that are accessing that. And I think we haven't nailed that previously, and so there's no reason to think that we're going to nail it brilliantly as well with long COVID. And given that, I think we need to be wary about taking templates and not really challenging some of the fundamental assumptions behind those and considering how we can shake it up, do things differently. You know, we could be doing things like designing from the outset for a better psychosocial experience for people, so that when people engage with our services, that we, you know, foster a belief in self and foster a sense of possibility for the future rather than exacerbate their psychosocial trauma. And I think we've already seen experiences of people with long COVID that say that we have exacerbated trauma, we haven't helped. And so I think we need to probably challenge some of those core assumptions. Yeah.
This feels like a good segue to one of our questions from the chat. Nikki Clake Baker asks, she chimes in, training needed. Sometimes no care is better than harmful care. So the question really was asking if the panel wanted to expand on the contraindications to treatment. Let's go in the same order to make sure everybody gets a chance. Simon, if you'd like to chime in as well at the end here, but let's start with Lisa.
Sure. Yeah. I think one of the things that we've experienced, especially with first wave patients, is that at the beginning and throughout, there's been a lot of dismissal of patients, a lot of being told our symptoms are all in our heads. And it's really due to this lack of investment previously in post-viral illness research and in training in medical education on these illnesses like myalgic encephalomyelitis and POTS, mast cell activation syndrome, things that have a lot of overlap with long COVID. So one of the things that I mentioned, which is getting a lot of attention in the chat, is that graded exercise therapy and cognitive behavioral therapy has historically been prescribed to people with ME/CFS, and it's actually contraindicated within that illness. If you have the symptom of post-exertional malaise or post-exertional symptom exacerbation, that can actually be very harmful for you. And there's a lot of studies on that. I can post some in the Padlet after. But it's often the first thing that providers will go to when they see a patient come into a clinic, and they want to prescribe that because that's what they've been taught to prescribe.
Yeah.
And it's actually really harmful and can result in more permanent and lasting disability. So we just need to make sure that when developing these care models, there is that medical education provided, that it's well known that that's contraindicated, and that people with post-exertional malaise with that symptom especially are not given that. That's not the first thing that providers go to.
Yeah. This is something that might look like something you're used to as a rehab professional. This responds, in fact, opposite to how it in your mind should be responding. And you were nodding along. What would you like to chime in on this topic?
Yes, I totally agree. I think that there is not enough known with the healthcare workers. I mean, I understand they've been busy, very, very busy the past couple of years, but there should be a way to educate them. And that education is so important because also all those people who go to their healthcare workers, who go to their doctors and come to me and say, they just don't believe me and they just say it's all in my head. And that's very harmful as well, because then you start to doubt yourself and it's really difficult to keep the belief in yourself because the people in your environment will also start doubting you, your friends, family, co-workers, your boss. It's really difficult to stay strong when everything is shifting in your life and everything is changing and you just don't know what's happening. And I think that's also very important to educate people so that they know what this is really about. I had this discussion yesterday. We're discussing here in Belgium what kind of neuropsychological tests we want to include. And I told them that for me, the first part, most important part is that we educate those neuropsychologists. Because, for example, my husband also has long COVID. And they told him that his long COVID symptoms were probably because of infected gums. I mean, even if his dental care wasn't as it was supposed to be, I'm quite sure that you can get those symptoms just because your gums are infected. And I do believe that all those people really want to do their best for us. But if they don't have the basic knowledge on what this condition is, they can't do that.
Sounds like some re-education from top down. We talk a lot about patient education, but we need to educate the educators. Sounds like a long COVID rehabilitation forum might be in order to educate those people. And that's what we're doing here today. Professor Kays, the same topic. I want to make sure you could chime in.
Look, I'm not sure what to build on from that, but I guess one of the things that comes up for me when I think about things that can do harm is lack of access to culturally safe, equity-oriented care where we're designing for equity from the outset. I think in New Zealand, we have an Indigenous population that falls on, the not so good side of our statistics in just about every level. And a large part of that is because of the structural racism that exists within our sector and health service. And so I think really addressing some of those systemic challenges is a critical step for us. Yeah.
Yeah. Well, we talked about sometimes the disconnect between large academic and then tactical, right? So Lisa, this comes from the chat. I want to direct it towards you. How about some specific screening ideas or questions? I mean, this is more tactics, right? Less strategy, more tactics. Some specific ideas for screening questions for post-exertional malaise at the initial eval, right when it starts. Any come to mind for you?
Yeah, I think the best one we have right now is the DePaul symptom questionnaire. Has specific questions on PEM or post-exertional malaise. So I will include a link to that in the Padlet, but that's a validated questionnaire that's been used for ME/CFS patients and now long COVID patients.
And I do want to front sell, to use some broadcasting language, the next session we'll actually be having is what is safe rehab, which we'll be discussing red flags and contraindications and what entails safe rehab. Let's go back to Simon. Simon, you brought in your presentation, and you're hearing this panel follow up. What is it sparking in your mind, or what directions is the next discussion needed to go in?
The discussion directly fits with how we are currently thinking our care model in Quebec. So it's starting as a network of clinic, and I wanted to have like one simple sentence as the culture that everybody who's going to work in that model across the province is going to have. And the culture is actually safety netting. It's a safety net. Let's be realistic. We are working with these patients, but we do not have the pharmacological options. And there are many patients who will need pharmacological option. You wouldn't go to a cancer patient in cancer rehab and say, don't take your medication, or rheumatoid arthritis. This, like, having pharmacological option is part of the rehabilitation of many diseases. And we don't have that yet. There will be advances in the next 12 to 24 months, but we are there. So there is many things we can do to help, but we are a safety net. So everything we do, so it comes back to Jimmy, what you were saying about less care, maybe better care, but less care, an assessment, helping them through the disability processes. That's a very important and safe intervention, but you are a safety net. And the way most of the models are designed right now is patients are going to be there. They're going to be supported and follow up until we have better option to help them. So you are a safety net for these people.
Look at the clock. I'm being told in my earpiece, I've got 6 minutes left, and we've got 3 guests on our panel, and I'm not great at math. It looks like 2 minutes per guest. So let's go in the same order. Lisa, Ann, and Professor Kays. What would you want to leave? What would your parting shot, the Long COVID Physio Forum, be? Lisa, you get to lead off with your parting shot. Your soapbox statement, your final sentiment you'd want to leave with the audience today.
Wow, that's a lot of pressure.
No pressure at all, I promise.
But I really appreciate, one, the work that you've done, Simon, on this. And I think just making sure when we're developing these care models that it really is accessible to everyone that needs care. Right now, what we're seeing in how this is being implemented is that, a lot of these clinics are requiring a positive PCR test that is going to exclude a huge number of patients that had COVID, just didn't have access to a test at the right time. These clinics are right now in very limited areas, largely urban, very few rural clinics. And the people who have access to these clinics are people who are largely already attached to the healthcare system. So people who have health insurance, who regularly see a provider. So we really need to also think through, how are we going to get to the patients who may not know they have long COVID, but have been experiencing symptoms since getting COVID, who may not have a positive test, but still deserve care. And people who, are more marginalized and normally would not have access to this type of care. So we really need to be framing it in that equity lens and making sure that it's as accessible as possible. And like I've mentioned before, just making sure that there's the quality of care there. There's one thing to set these clinics up and have the infrastructure, but if it's doing harm, then there's not really much good in having that infrastructure there.
Some discussion around exactly what Lisa was talking about before, asking someone if you've tested positive for COVID. There was this answer, which was an inhale, a pause, and and not knowing how to respond, because, as you mentioned, they might have had access to a test. They don't know how to respond. You said there was some pressure with your parting shot there. You did great, Lisa. Well done. And we come to you. How would you like to wrap up? What would your final thought be?
Oh, so now the pressure's on me. I think that I would say that when in doubt, give us, the patient, the benefit of the doubt. Not because we are experiencing this day after day, year after year, but also because there are so many people who have expertise in certain areas, and you can use that area of expertise. I mean, we're not just sick people. We are healthcare workers. We are economists. We are politicians. We are whatever. I mean, look at Darren. He was sick. He got long COVID, and he set up this wonderful meeting today. I mean, with a lot of other wonderful people as well, of course. But we're not just sick people, and we hate that we are just lying there and we have to wait until somebody will do something. We really want to get out there and be of meaning to however we can find a cure for this.
When in doubt, give the patient the benefit of the doubt. That is a parting shot right there. Let's see, Nicola, how would you like to wrap up with your parting shot?
Goodness. I think ultimately we only know what we know about long COVID because people have shared their stories and experiences, and that has led us to where we are now, and where we have the opportunity, this extraordinary opportunity, to design services from scratch, informed by people with lived experience. And so I think we need to take that opportunity by the hands and build person-centered cultures of care where the structures, the processes, the systems enable rather than compete with the aspirations of person-centered care, so that we can meet people where they're at, listen, be critically reflexive in an ongoing way, and keeping on building on that.
Excellent. Thanks so much. Simon, we'll give you one more chance for your parting shot to wrap things up as we move on.
I just want to say that my colleagues, you're all awesome, and we have a lot of work in front of us. Thank you very much.